Morning, everyone, and sorry about that technical hitch just there. I think it was something at my end. But good morning. Really, really good to be back here at Health Careers Live again. As Jono said, I'm Tista. I head up outreach operations at the General Medical Council, and we're going to be talking today about surviving the NHS, but not really surviving. I hope we're also going to be talking about thriving in the NHS. So before we get into that, I just want to extend a really, really welcome to you, wherever you are, whether you are joining us internationally, whether you have started UK practice recently, or whether you expect to qualify here and start UK practice. A huge welcome to all of you. As I say, what we want to do today is explore surviving and thriving. So we're going to look at challenges as well as opportunities. And as part of that, I'm going to be sharing resources and avenues of support for you as well. But first, by way of brief introduction, before we do that, I've been in and around healthcare for 25 years now, which feels like an awfully long time, but it has been a marvellous time as well. I started my career in healthcare by working with survivors of abuse in the SARCs, those are the sexual assault referral centres. And during that time, I became really interested in how when system partners, when the system in general doesn't cohere as well as it could, our patients, our clients can fall through the gaps. And therefore, I started to do a lot more work in healthcare systems as well as one-to-one work with survivors. And as part of that, I became interested in regulation. So it was just over 10 years ago that a colleague and I were asked to join the GMC to set a support service on the ground. And I remember thinking at the time that this was a really progressive thing for a regulator to do. I was really enthused, really excited to be at the vanguard of something where regulators are there on the ground providing support. So I jumped at the chance. And then about I think it was only a few weeks in to the role, at one of my very first conferences, I was introduced onto the conference podium to the theme of the Imperial March, Darth Vader's theme, for those who don't know. And that moment really crystallised for me that whilst the organisers were joking, I like to think, we can be held in extreme fear. And I understand why we are predominantly in fixed practice terms. But as I learned more about the GMC, and these are all our statutory functions now that you can see on the slide here, it became really, really clear to me that standards there at the centre in that image, standards are the absolute fulcrum of what we do. And what I mean by standards is supporting doctors on the ground with very, very complex ethical challenges, raising concern scenarios, all of that kind of thing. That the support we provide around standards informs absolutely everything else we do. And I would argue actually that that's more important for patient safety in many regards than fitness to practice, because the really serious fitness to practice that we see is tiny. So the more that we can do as an organisation with system partners to provide you with support on the ground, with what are, let's face it, challenging standards in an increasingly challenging environment, well, logically, but most importantly, morally, that. So that ended up being the sort of thinking behind the service that we set up. And this is what GMC Outreach do. I'll just let you digest that. So that's what my team do. We are there on the ground, providing those supportive teaching interventions, but also importantly, hearing what's happening and providing that support directly, locally, when things aren't going how they should be, whether that is, as I say, directly, or whether that is a more broad brush thing where policies and such need to change. Wherever you are in the country, you have a point of contact in terms of GMC Outreach, and if it is useful to, for example, if you are working in a stroke ward, thinking the way that we're doing shared decision making here doesn't feel right, we'd like some more support around it, then we can come and provide that. So that is what we do, and here we are on the ground with students here and with international graduates here as well, providing that teaching. And without further ado, I now want to think about what concerns about starting UK practice. And we've got a question on Slido, so if you could launch that, please, and just start typing in your concerns. And if you already have started, then try and put yourself in the shoes of when you were going to start. What concerns did you have? Just need to toggle your responses because they're quite small on my main screen. Start typing in. Can I check if that poll's been launched so people can type in their thoughts? Okay, I'm not sure that first poll is running at the moment. Ah, here we go. There we go. It's just launched now, I can see. So yes, so just start throwing your thoughts in there. What worries do you have? And if you can't access the Slido, if you flick onto the Slido, you should be able to type in your thoughts there. Brilliant. I can see a couple of people are connected to that now. So I'll just keep an eye on that for a moment as we get our thoughts through. And whilst I keep an eye on that, I just want us to consider another question. And for this, feel free to just type into the chat. I'm going to share some bullets with you. And as I'm sharing these bullets, have a think about what you think this list represents. Now, as I go through, you should start to recognise what this might represent. And by this stage, most people have it. I'll just flick through and see if it's there in the chat. Yeah. Okay. So this list represents induction. And this is actually a real list. My friend who qualified in Sudan and started here, this was the gamut of her induction, the absolute totality of her induction. This is all she had. A lot of it was e-learning, and then 2 weeks later, she was on the wards. And bearing in mind that she qualified in a country with wildly different practice in many regards, you know, where is this piece about culture shock? Where is the piece about different legislation, different patient expectation, the different system? Where's the welcome and thank you for coming to the NHS, by the way? It's quite complex. This is how it works. This is where you can get support. Where is that support? I am absolutely horrified that this is what was provided as induction, but I have to say this isn't an unusual set of circumstances. Her experience is common to many international medical graduates. Okay. And I'm just going to share some quotes from focus groups that we ran with international medical graduates. And you can see the range of experiences here range from, well, they're really poignant. They range from sad, really, really sad, to, well, dangerous. That penultimate quote there, that is a colleague who in his country of practice, of qualification, there was one type of catheter, unisex catheter. And then coming to practice here, no one told him that there are male and female catheters here. He was working on a male ward, and he was told to go and get the catheter, as it says here, from the cupboard. And here's another systems issue, another human factors issue, in that there were both male and female catheters in that cupboard. He picked up the female catheter. How was he supposed to know any different? And that is patient harm and colleague harm. And it was absolutely, eminently preventable. And we know from our research that, this is some, and you can see some of the themes from our research here on the experiences that international medical graduates have. That lack of support is stark, and support is needed on practical stuff like visas, as well as that induction into the culture and language of the NHS. The different clinical areas, but also, as I say, the different legislative and ethical picture. There are other challenges besides induction in the NHS. There are a couple of reports that we commissioned not too long ago because we were particularly concerned about disproportionate referral. And this isn't just for international medical graduates. This is fairness around ethnicity as a factor. And we were concerned about well-being across the piece. So these are two reports that I can't recommend them enough. Please do, if it's only the exec summaries, please do access them, because there are some really, really important findings and recommendations here. And just to summarise a few of those, thinking about fairness first, Fair to Refer makes findings around these 6 themes. So these are some of the issues that we see, and I'll pause for a second so you can just digest those. Now, by way of reassurance as I said before, the overall really truly serious issues that we see are tiny. They are very, very low, and our thresholds as well are much higher than most think. When we run talks on fitness to practice, on complaints, that's something that comes through powerfully. People are very, very surprised. And ultimately, you know, it's very well recognised that you'll make mistakes in practice because you're human. We all do. And even if the outcome is poor and leads to, well, unexpected death, that in and of itself is not a fitness to practice issue. It's what happens after, the reflection, the insight, the learning from that, whether there are any other professionalism or performance issues, is what would make it fitness to practice. Okay. And the problem that we see in terms of disproportionality is that after that incident, after a mistake, as I say, that we can all make because we're all human and we all will make, is that our ethnic minority colleagues are less likely to receive that early support that is needed. And that's something that we're really, really urging employers to focus on, because we think that that could make a huge difference in terms of that disproportionality. But in addition to, you know, employers have the responsibility to make that change. But it is also useful for us to know where mentoring and networks are available, because they can really, really help you as well. And knowing your support sources of support in general, really helpful. And we'll be looking at some of that today. So that's on disproportionality, but just turning to well-being. The themes from the Wellbeing report we commissioned are grouped around, very neatly, I think, around ABCs: autonomy, belonging and control, and competence, where the report is saying that we need to feel that we have autonomy, we need to feel like we belong, we need to feel that we are able to be competent in our work, that our environment allows us to be competent. Those factors all need to be in place to promote well-being. And it, of course, delves deeper into, for example, around feeling competent. Well, our workload needs to be reasonable so that we can feel competent. And I'll come back to that in a moment. But it's worth noting that the report also highlights that there is some really, really good practice around this, as well as poor practice. So that means that some places are getting this right. And there is lots and lots of good learning that can be spread. So again, it's a very valuable report to try and promote that culture that we need around well-being. But to focus in again on workload for a moment. Some of us in the system have been feeling for a good while now that workload feels like an increasingly Sisyphean task at times. And I'm just going to give you 10 seconds now when I share the next slide to just type into the chat, if you would, when I reveal this, what you think the mistake is on this slide. So I'm just going to reveal it now. I've got 10 seconds to find the mistake, and I'm just going to look at the chat. Anyone got it? Okay, so I'm going to share the answer with you, and people tend to kick themselves if they don't see it. Can you find the mistake? The is repeated. And this slide, you know, it's designed to hoodwink you because we've got the different colours, we've got the different font sizes, and that distracts you. And bear with me for a moment, but I would say that that is somewhat analogous to working in a busy service where you are in that pressurized environment. There's a lot of different stimuli, lots of different things going on. It can be easy in that environment to miss things. And we sometimes hear that when we have extremely pressurized environments, everything else must drop, because service delivery, frontline patient care, of course, is critically important and takes precedence. I agree, but I would also say that the space to think is incredibly important, and we can't lose that. We can't lose that in terms of well-being, but also, well, you need good well-being to make sure that you, well, don't burn out, but also don't miss things, that, you know, that they are linked. So a question for you. I'm not sure the polls are working quite as we want, but we'll give it a go. We've got a poll on the next slide, and if it doesn't work, it's fine. I can just talk through it. So this question from a study that was done. What do you think the characteristics or presentation was that was most associated with dehydration on an ICU over the study period of 22 days? And if you can't see the poll, just make sure, yeah, the poll is up and running. So please just enter a word if you can access that, whatever you think the answer is. What presentation do we think was most associated with dehydration? I'm just looking in the chat now because quite a few people are typing into the chat. If that's easier, feel free to use it. And I can see quite a few of you got the previous slide actually on the Any thoughts on dehydration and the most and the characteristics associated with that? Okay. I'm going to share the answer with you, and I wonder if it might surprise some of you. It's a little bit of a trick question. Well, it is and it isn't, because, well, the answer's true. Dehydration is twice as frequent in junior doctors in ICU compared to patients. So that was the characteristic that was most significant. And thinking about, and this was way before the pandemic, by the way. So turning our minds to the pandemic, let's try loading the next poll and see if you can access that, because I'm going to ask you. So during that first peak of the pandemic, what percentage of doctors do you think reported that negative impact on their mental health and well-being? So I'll give you a few moments to hopefully access and respond to that poll. I can see a few people are connected. So let's see if the results are going to come up. Okay. Right, we've got a few people connected, so once we've got those votes coming in, yeah, it looks like we've got a few responses coming in now. Can we just share the results on the screen? It's good to see that this one's working. So hopefully you can see that there are a lot, the majority, I think, have responded, 62%. Now, it was actually 32% on our survey, but a BMA survey not long after said 45. So it's, 23% would be too many. The important thing here to consider is that a huge number of colleagues in the system were feeling and are still feeling those negative impacts, and scenarios like that, you may have heard of this term, can lead to moral injury. Okay. And I want to now think about how we can help tackle moral injury. There are things that need to change in the system, but from a personal well-being point of view, there are things that can help us. And something that I've personally found really, really useful in terms of surviving and thriving in the system is thinking about my values. And colleagues in psych came up with this as a tool to use. And I want to start by looking at the bottom right quadrant, where we think about what our values, our core values are at work. And just think to yourselves for a moment, what core values do you want to, I guess, demonstrate in the working environment? And I'll share with you what I put down when I did this exercise, thinking about my work in sexual assault referral centres and domestic abuse services. So these are the values that I want on display. To those that I see, service users, clients, patients, depending on your setting, and my colleagues as well. These are the things that are really, really important to me in terms of my professional values. And then moving on, what do you think and feel when the context, the environment, doesn't let you meet your core values? Well, this is how I feel. You might have had different thoughts as you were thinking through this. It's a really useful exercise to do when you are reflecting, perhaps ahead of things like appraisal, ahead of mentoring conversations, etc. And see what you think. But before my appraisal, this is what I jotted down. And when I am thinking and feeling those things because my context doesn't let me live my values, what I'm doing changes as well. So have a think again yourselves. What are you doing when working at odds with your values? What changes? What are your behaviours like? What are your actions like? Now here are mine. My actions become a lot more rushed. I certainly don't communicate as effectively or as much. And I lament the areas where I think I could really do something here that would have value, but I don't want to concentrate. Well, I haven't got time. I haven't got the headspace to focus on that. And I regret there are loads of things that I deprioritise which do have value, that could really add value. And then, as I say, I really regret that. And interestingly, for me, I don't know if others find this as well, but when I have got a lot going on, I find that I switch off less and work well into the night a lot more than I would when workloads are a bit more reasonable. And when that might be obvious in terms of the volume of work, but actually what I mean by switching off is I think about it even when I've come back home or my laptop's off or whatever, it just stays. I don't switch off and have me time, family time, whatever. And certainly take things home with me emotionally a lot more. But when I am working in line with my values, then I'm a lot more creative. I get involved in areas like quality improvement a lot more. And I'm just generally more collaborative, more supportive. And it's, as I say, a useful exercise to undertake because it can be an early warning sign, really, that moral injury might be on its way. But it's also a way that those who help develop this tool that can lead to moral growth in terms of, well, the opposite, really. It's a really supportive thing to do. So, as I say, it's one to take away and think about, and as a bottom line, if you're not living your values, I guess that is your warning that you need to access help, support, etc. So turning back then to where you can get support. I remember our former chair always used to say that the best way to keep patients safe is to keep healthcare colleagues safe, to keep doctors safe. But actually, I have always thought, and I'm sure he meant this as well, that it is morally right to ensure that healthcare colleagues, in and of itself, it's morally right to ensure that healthcare colleagues have a supportive environment. And there's a lot of work in that space. It is not spread the way that we would like it to be, but there is a lot of work in that space. Some of you may have heard of our programme and work that we do. Well, I've touched on work that we do around fairness and well-being from those reports and the work that's coming from those reports, but also around reflection, induction, etc. And just think for a moment, back to what I was saying before, there are challenges that sometimes mean that we feel like we have to survive the NHS. But the way to ameliorate those challenges is having support. The system has an unequivocal moral duty to provide that support, but it's also useful on a personal level to know what resources and support is available to you. So let's think about that. What support is available? There's loads. And I don't think that we as a system necessarily do a great job of sharing all of that. That's why the space to think in conferences like today and general reflective time is so very useful. Some examples of some of the support available. I'm just going to draw on a few of these as examples, but the Head Start project is a project by IMGs, International Medical Graduates, for IMGs. And there's all sorts there, a series of really useful peer webinars. I spoke recently at one of the events, Facebook, networking, all sorts. We've all heard, I would imagine, about the challenge that there can be in speaking up. And that is recognised by the system. And that's why the National Guardian for Freedom to Speak Up exists. And every trust in England has a Freedom to Speak Up Guardian that's an independent of the employer, of reporting lines to be able to provide that support. And there are other examples here, organisations that you will have heard of, organisations focusing on things like civility, mentoring. And then from the NHS itself, there are loads and loads of tools available too. And does. In addition to the outreach team, there's loads on our website. There are loads of events, all kinds of things. So please do avail yourselves of this support. And I just want to hone in specifically on the standards. So I was talking earlier, right at the start, about how standards are the fulcrum of what we do and inform everything else. And I'd say that as well, that standards are one of your biggest sources of support. Now, sometimes we hear that good medical practice is perceived as common sense. And in fact, I've been at medical schools where the speaker ahead of me has said, this will be really useful for your SJTs. And I know some of you are joining that session later on today. But yeah, the speaker in front of me has said it is useful to be aware of, but just so you know, it is all common sense. And actually, the next slide, which is horrible, and I don't expect you to read it, that's the point of the slide. That's a list of every single piece of legislation that we distilled to put into just one piece of guidance. In this case, the confidentiality standards guidance. And what that means is that you either need to know all of these 47 pieces of legislation, or the bits that are salient to healthcare, or confidentiality standards. You need to know those. You need to know the themes there. And that's just a lot more practical, because what our ethicists, the ones in the offices do, or virtually at the moment anyway, remotely at the moment, they look at those salient bits in each of these bits of legislation, and they look at the wider ethical framework, and they then put it into a more digestible document for you that serves as standards and guidance to support you. And that means that all of those booklets that were on a couple of slides ago, they're the benchmark for practice. They're not just the nice to do's when you can. They're also the safety net for your decision making, the safety net for you and your patients. And I should say here as well that those standards and guidance documents are available to all. Yes, the General Medical Council, as it stands, is for doctors, in terms of the regulator for doctors. But I know, for example, a lot of nurse colleagues tell me that they value the end-of-life care guidance in particular because of the detail that it goes into. So it's accessible for all, to be clear. Yeah, so it's that benchmark, it's that safety net, whatever your career in healthcare, the decision making, because it's a wider ethical framework that applies to all of us, and because it takes in legislation that applies to all of us. But importantly, I also see it as a lever for change. And what I mean by that, I gave an example earlier, I think, of what if things aren't going the way they should be in terms of shared decision making on a stroke ward. We hear about things like that all the time. And I remember a group of my F1s years and years ago now. We were teaching on a number of areas, so we'd gotten to know them really well, a great group. And they had concerns about the design of a new SCABU, that's a special care baby unit. And their trust, when they'd mentioned this, when they'd said, we've got some ideas around this, their trust had said, you're F1s, that's not your job, don't worry about it, you're here to do and not think. But because they knew our standards, they knew that not only do they need to get involved in relevant quality improvement activity and improvements around services and outcomes, but their organisation has a responsibility to allow them to do that. And our guidance on leadership and management was then used as a lever to get them into that quality improvement project. So that's what I mean. The standards are that benchmark, that safety net, but also a lever for change. They can support your practice, they can support your environment. So, thinking specifically then about the differences in UK practice, so turning to our internationally qualified colleagues here. We have a course called Welcome to UK Practice that looks at all of those standards, and it's a free half-day workshop. It's currently being delivered virtually, although we hope to start returning to face-to-face as well from next year. And it looks at some of these areas that we were talking about before in terms of the challenges that our international colleagues can face. There are other tools as well, but Welcome to UK Practice is particularly pertinent. And I won't ask you to launch the poll now. I'm just going to talk through the next couple of slides, but have a think. What percentage of doctors who attended, after attending Welcome to UK Practice, do you think, say, would change their practice after attending? Now, normally the response is either B or C, the majority response, but it was actually 91%. Oh, just go to the previous slide. There we go. So, all high numbers there, but 91% saying that they would change their practice as a result of a standalone educational intervention. That is remarkable. And yes, those are the evaluation forms that are given out at the end of the session, but actually we've got academically robust evaluation as well, and that shows that at time 2 follow-up, people had actually changed their practice. And just this morning, in fact, there's a webinar ongoing today, and colleagues speaking at that webinar, I saw myself tagged in a tweet to say that she had attended Welcome to UK Practice twice and found it incredibly valuable. So in terms of that support, it makes a huge difference. And just to note, Welcome to UK Practice is part of the picture. There needs to be a wider, broader standardised induction, and that is something that is being worked on. But in the meantime, Welcome to UK Practice is available. And a resource that I'd like to share with you all, whether you are internationally qualified or UK qualified, I cannot recommend enough that you just click on this video link and have a watch of the Things I Wish I'd Known video that will give you some top tips, as I say, wherever you qualified or are qualifying, and will also give you an understanding of some of those challenges and opportunities. It's only a short video, 10 minutes or so, and well worth watching. So just to wrap up, I want to have a moment to reflect on what we might take away today. So we ended there talking about challenges again for internationally qualified colleagues, but more broadly, I want to think about all of us. What support is there? What opportunities are there? We know what challenges there are, so what can we do to overcome those? What can help you as international graduates or as UK graduates? And my takeaways are to be familiar with the guidance, remembering that it's that benchmark, that safety net, and also that lever for change. Accessing all of those resources that are relevant to you, that resonate with you, that I shared before, knowing that those resources are available and accessing them. Knowing where your local support is in terms of peers, supervisors, mentors. And if you're qualified internationally, attend Welcome to UK Practice as well. So they're my takeaways. I am going to stop sharing my screen now so that I can see your questions. And let me go on. Well, I'll go back onto the main section so I can see if we've got any chat or questions, and I'll hang around for a couple of minutes to answer those. But thank you very much. I hope that was helpful.